So today we will discuss about Andrew's 6 keys of normal occlusion. There is no diagnostic way to measure or accurately estimate malocclusion, nor to decide how closely treatment has approached good result until we first know what normal or good occlusion is. So it is very important to know what a good or normal occlusion is. Then only you will be able to differentiate between the normal occlusion or an abnormal occlusion. So six significant occlusal characteristics identified and first reported in 1972 by Lawrence F. Andrews. So he gave the term the 6 keys to normal occlusion. So these 6 keys were found to be consistently present in a collection of 120 models of teeth with the natural excellent occlusion who have gone on non-orthodontic treatment. So basically he collected 120 models of non-orthodontic treated models, and he evaluated his 6 keys to normal occlusion. So the keys tell about the characteristics of static occlusion. So Ronald H. Roth declared 6 keys to be consistent with desirable functional occlusal goals, provided that the occlusal interdigitation occurs with the mandible in centric relationship. So he gathered data from 1960 to 1964. 120 non-orthodontic normal models were collected with cooperation with some orthodontist and general dentist in San Diego University of Illinois. So the first key which he gave, that the non-orthodontic normal models consistently demonstrated that the distal surface of the distal marginal ridge of upper first permanent molar contacts and occludes with the mesial surface of the mesial marginal ridge of the lower second molar. So this is how your molar should occlude normally when they are in occlusion, or by orthodontic treatment. Your choice should be to get a ideal molar relationship where the distal marginal ridge should also occlude. So the mesiobuccal cusp of the upper first molar permanent molars falls within the groove between the mesial and middle cusp of the lower first permanent molar. The mesiolingual cusp of upper first molar seats in central fossa of the lower first molar. The premolar enjoys a cusp embouchure relationship buccally and a cusp fossa relationship lingually. Maxillary canine has a cusp embouchure relationship with mandibular canine and first premolar. The cusp tip is slightly mesial to embouchure. Maxillary incisors overlap mandibular incisors, and midline of the arches should match. The second key was crown angulation. That is the tip of the teeth. It should be viewed from the mesial or the distal perspective. The facial axis of clinical crown is representative by a line that is parallel to the mid-developmental ridge or the molars, the dominant groove, and tangent to the middle of the clinical crown on the labial or buccal surface. So the crown angulation refers to angulation or tip of the long axis of the crown, not on angulation of the long axis of the entire tooth. So we are talking about the long axis of the crown. It is not about the entire tooth, because these things come into the aesthetic corrections also. So as orthodontists, we work specifically with the crowns of the teeth, and therefore crown should be our communication base or referent. So the crown angulation or tip, the degree of crown tip is the angle formed by the FACC and the line perpendicular to the occlusal plane. A positive reading occurs when the gingival portion of the FACC is distal to the incisal portion. A negative reading when the gingival portion of the FACC is mesial to the incisal portion. Key 3 is crown inclination, that is the torque. Crown inclination is the angle formed by the line which bears 90 to the occlusal plane and FACC as viewed from the mesial or distal surfaces. A positive reading is given if the gingival portion of the tangent line or the crown is lingual to the incisor portion. A negative reading is recorded when the gingival portion of the tangent line or of the crown is labeled to the incisal portion. So this is what is the torque is a positive torque and a negative torque. Positive torque is when the root is going on the palatal side, and negative torque is when the root is coming on the labial side. So this is how the torque is expressed. In posterior teeth, the posterior crown inclination in upper arch, a minus crown inclination for each crown from the upper canine through the upper second premolar. A slightly or more negative crown inclination exists in the upper first and second molars. Posterior crown inclination in lower arch. A progressively greater minus crown inclination exists from the lower canines to the lower second molar. So you can appreciate the inclination of the posterior teeth in the mandibular arch. Key 4 is rotation. That teeth should be free of undesirable any kind of rotations. Rotated molar will occupy more space than normal, creating a situation unrespective to the normal occlusion. Tight contacts, the contact should be tight and there should be no spaces between the teeth. Key 6 is the occlusion plane, that is the curve of P. Depth of the curve of P ranges from flat plane to slight concave surface, that is 0 to 2.5 millimeter is the normal range of curve of P. A flat plane should be treated goal as a form of over treatment. There is a natural tendency of the curve of P to deepen with time. So we always try to make it flat or get it over corrected, because with period of time it again deepen up and so it forms into a normal range. Intercuspation of teeth is best when the plane of the occlusion is relatively flat. There is a tendency of curve of P to deepen after treatment. During treatment, the plane of the occlusion should be flat until it is flat or reverse or allow for this tendency. A deep curve of P results in more contained area of upper teeth, making normal occlusion impossible. Only the upper first premolar is properly intercuspally placed. The remaining upper teeth, anterior or posterior to the first premolar, are progressively in error. So deep curve of P is also not accepted. Rather, a reverse curve of P, if it is during the treatment you have given a more curve of P at the end of the treatment, the reverse curve of P is extreme form of over treatment, allowing excessive space for each teeth to be intercuspally placed. So if there is excessive reverse curve of P, there will be gap between or spaces between the upper and upper teeth. So the seventh key, although there were 6 key, but 7th key was added by Bennett and McLaughlin. So according to them, the Bolton discrepancy is considered to be the 7th key. So Bolton discrepancy, as you all know, it is the relationship of upper and lower anterior teeth. So if upper and lower anterior teeth are properly aligned and they have a proper relationship to each other, then only a proper intercuspal relationship, a proper overjet, overbite, and a proper aesthetic can be attained. So Andrew's non-orthodontic models have shown tooth size discrepancy. It would have resulted in either spacing or crowding in either of the arches until compensated by depth and torque in anterior segment. So discrepancy may exist prior to treatment, but frequently not noticed until the finishing stage. So when you come up into a finishing stages, when you are finishing your orthodontic treatment, so if there is any kind of Bolton discrepancy is there in the anterior teeth, there won't be a proper finishing or aesthetic result won't be attained. So the potential need for interproximal reduction to decrease the tooth size in one arch or restorative procedure to increase the tooth size in opposite arch should be discussed with the patient or parents before the treatment, that these things has to be done because there is a Bolton discrepancy in the patient. So we need to take care about these things. So when possible, 6 keys should be our measure of static relationship for an successful orthodontic treatment. Achieving the final desired occlusion is the purpose of 6 keys to normal occlusion. Thank you.